think of the case logically and come up with at least somewhat of a decent answer to some of the questions I'm asking. So if you ever get stuck and you don't know what to answer, just try to take a step back, think of what you would potentially do or what the next probable step would be if you're just thinking about it logically and based off of what's in that area, and then and you're probably going to be right. And the reason why I did this is because that's a lot of what abdominal pain is, and I want you to go through the process without being bogged down with all the different things that can be happening in this patient or in patients with abdominal pain in general. So just keep that in mind, and if you don't know something, that's okay. You can just tell me you don't know, and that's fine. Okay, so give me one sec. All right. So let's start off with Dr. Joshi. So we have a 56-year-old male with a 30-pack year smoking history and hypertension is coming into the ER with worsening abdominal pain over the last 2 weeks. Pain is located in the upper abdomen and feels like a pressure pain, tip pain, and with discomfort. So with that history, what is significant and what are you thinking about?
So I read that with hypertension, it can over time affect certain organs, particularly like the kidney. So I was thinking, also just like reading along with his back pain, I was assuming that there was something possibly wrong with his kidney.
Yeah.
Smoking history could probably also affect other organs as well, just because of the carcinogenic nature, and then because he is elderly, like diseases can progress more quickly over time.
Yeah, so definitely, like the hypertension causes changes to the vessels. It can cause some thickening. It can cause some narrowing of the vessels as well. So you're going to want to think of that, and definitely, like what you're saying, the patient's going to end up has back pain. So we're going to talk about potentially affecting the kidneys. So good. What about the smoking?
Was this question for me also?
Yeah. It's for you also.
Okay.
Why is the smoking important?
I would say it could. I was thinking that's because smoking can have impacts on the lung. I was also assuming that it could also affect other organs as well, like because nicotine is like a carcinogen.
Yeah.
It can affect like the liver or kidney, things that process toxins. So that could also aid in causing like abdominal pain.
Yeah. So what are we worried about with smoking? Like, what is the one thing that we're like, oh shoot, you're smoking for a long time? What can that cause? Basically, is what I'm asking.
Lung cancer.
Lung cancer, right? So, but you said it yourself. I mean, smoking, the contents of the smoke and what you're smoking is a carcinogen, and so if it's a carcinogen in the lungs, it can potentially be a carcinogen in other places too. So you can have cancers in other places. So good, very good job. And then additionally to that, it can cause some narrowing of vessels, and so if we have somebody that has coronary artery disease because of smoking, you can also have narrowing of the vessels going to the intestines as well, and it can cause something like ischemic colitis or mesenteric ischemia, where you're not getting enough blood flow to the gut. So that's something to keep in mind as well. So good job. All right, so Dr. Stewart, this patient also has been having pain in the. So this patient has been having pain in the upper abdomen. So what do you think of when we talk about upper abdominal pain? Let's go with Dr. Takemoto. What are you thinking of for upper abdominal pain?
So I was thinking with the not being able to eat as much and like feeling full, that it was something more towards like gastritis with his stomach.
Okay, Possibly. So what else is in the upper abdomen? We talked about the stomach. What else?
The liver, the spleen, the lower lungs.
Okay, good. So things outside of the abdominal cavity. What else?
I'm not entirely sure.
Okay, so we talked about, so we got liver, lungs, spleen, stomach. We said, what's right next to the liver? What's like tucked underneath the liver?
Gallbladder?
The gallbladder. All right. And so on the other side of the stomach, you have the liver on the right side. What's on the left of the stomach? Oh, you said spleen. Sorry.
Yeah, sorry, it's okay.
Okay, so what about what's right next to the stomach, kind of underneath it?
Pancreas?
Pancreas. Good. And anything else towards the back?
The aorta is towards the spine.
Good. Aorta. Okay.
Everybody's saying kidneys.
Yeah, the kidneys too. But yeah, the aorta definitely as well. So good. And so if we thought this was an aortic problem, what type of pain would they be having? If they're having
sharp, sudden pain.
Yeah, sharp, sudden, tearing type pain radiating to the back. Perfect. All right. And so we'll stick with you. So he has been having difficulty eating, getting full easily, and he's lost 20 pounds over the last month. So with his weight loss, what are you thinking of? Or what's the number one question you have to ask him with his weight loss?
I'm not sure.
Okay, so if he, is there going to be a difference between a 60-year-old guy that's not really exercising and he's losing weight versus a 20-year-old that is exercising, dieting, and losing weight?
Yes.
Okay, right? So one is intentional, the other one isn't, right?
Right.
So why is that important to know?
Because like the weight loss could be caused by whatever is causing like the pain and the uncomfort in the upper abdomen versus like somebody younger who's doing that on purpose to stay healthier.
Yeah, so if you're intending to lose weight, I mean, good job, you're losing weight, you're doing great. But if you're not intending to lose weight, then there's something seriously going on. Either he's not really eating because he gets full too easily, so maybe that's why he's just not getting enough nutrients that way. But what else can cause weight loss that you're worried about?
I don't know.
Okay, that's okay. Dr. Azam, what else causes weight loss that you're worried about?
I would say if he has a severe infection or something like cancer, it can cause severe weight loss over a short amount of time.
Yeah, so how does cancer cause weight loss?
Since cancer produces like a mass amount of cells, and those cells require a lot of nutrients and energy. And if those cells need those nutrients and energy, it's gonna be less energy given to the cells that need it and like is necessary to get energy. So I feel like there's gonna be a loss in weight.
Yeah, so cancer basically is a bunch of cells that are growing out of control that you're not able to control, and so they're dividing rapidly. So every time a cell divides, it requires a lot of energy, and so because it's dividing so much, all of that energy is being diverted to the cancer. The cancer itself will start to make its own blood vessels. It'll start recruiting more blood vessels to it, so that can also divert some nutrients. But because all those nutrients are being diverted to the cancer, the rest of your body's not getting as much, and so your body will start breaking down like fats and deplete your own stores so that it can keep up with demand. And after a while, you're gonna start losing weight because you're using way more energy than you are putting in. And so so that's typically how cancer makes you lose weight. And the biggest part of that is whether or not it's intentional. So that's a really good question to ask. So good job, guys. So Dr. Patel, the most bothersome symptom for the patient is this progressive fatigue. And so over the last month, he hasn't really been able to keep up with his daily activities. He gets tired too easily. He's a construction worker, and it's been hard to get through his day. He has to rest about every hour. So what is important about that statement? All right, let's go with Dr. Alfaro. What's important about the fact that he's not able to do his daily activities and he's getting tired easily? Let's go with Dr. Perez. All right, so Dr. He, tell us what's important with that statement.
So what I thought was that it was significant since he's a construction worker and because of that, right now he's not really performing normally. So that means that there is a significant change from what is normal to him and from the baseline, which kind of indicates that there's something really significant going on that is affecting him.
Yeah, so he's a construction worker. He should be able to do those daily activities, and he should be able. I mean, I'm sure he's been working for a long time and working for hours on end, and so the fact that he has to rest every hour is pretty significant. The fact that he can't do his daily activities because he feels too tired, super significant. So that tells us that there's something really wrong going on with this patient, and so. He also admits to some dizziness when he gets up too quickly, and it's made his work even more difficult. So, Dr. He, is that important to know, or is that something that's normal?
I think it's important because it could be indicating that he has low blood pressure. It's kind of also indicated by the medication that he's taking. And I guess when he tries to get up too quickly and if he feels dizzier than normal, yeah, I think that means blood pressure. Because I think you always say that cardiac output is a function of volume and heart rate. So he probably has really low volume since later on they also indicate that he does have increased heart rate.
Yeah, so anytime we stand up, our blood pulls down to our feet because of gravity, right? And so if there's blood that is pulling down to our feet and not going back up to our heart, or the volume is not the same going back up to our heart, our body's going to want to compensate to make that cardiac output the same. So the cardiac output is basically how much volume is coming out of your heart at a certain time. And so your body's going to want to maintain that cardiac output so it can perfuse all the organs well enough to, survive and be functional. And so as we stand up, the volume goes down. We have less output from the heart. So the cardiac output being a function of stroke volume and heart rate, if the stroke volume goes down, the volume that's coming out of the heart goes down, is going to compensate by raising up that heart rate. And so what you guys can do is, if you're sitting down, get up really quickly, just be safe to make sure you don't fall, and feel your pulse. You should feel your pulse increase a little bit. And so that's okay for us. We don't really get dizzy often unless we get up way too quickly, because our body's able to compensate. We have enough volume for our body to work with. And so that is something that the normal would be, not being dizzy. And so the fact that he's getting dizzy, and if it's pretty persistent, that tells us that he might have a volume issue. So good job. All right. So, okay. So Dr. Wright, he's been having ongoing back pain for the last 2 months, more notable in the left mid-back. It's a deep ache. Nothing is making it better. What are you thinking about with that?
So with the back pain, I was definitely thinking about the location of his kidneys, as well as the descending aorta and various other muscles. The one with him being the the worker, he could have done something to strain a muscle in his back, or it could simply be a failure of the kidney or a organ.
Yeah, so good. That's exactly how I want you guys to be thinking about this. Like, what is in that area? So he's having back pain, kind of in that mid back on the left side. This is my right side, but on the left side. And so he in that area, you have muscle, you have bone, you have going a little bit deeper on the medial side. In the middle, you have your aorta. On both sides, you have your kidney. So all of those can be causing some back pain, right? You're right. He's a construction worker, so he's straining his muscles a lot. So maybe it's a muscular issue, but I mean, if we're to be going on for, what did I say, 2 months, less likely. Although you can have some pretty bad strains, especially if you're restraining it over and over again, that can cause that. So, Dr. Takimoto is saying that with the UTI, it could have maybe gotten worse and affected the kidneys. Definitely, if you had a kidney infection from a UTI, you're gonna have some pretty significant pain with that. So yeah, that can definitely happen. Good. So Dr. Tarango is saying that I looked up side effects for lisinopril hydrochlorothiazide, and fatigue is a side effect. So Dr. Tarango, can you explain why that medication can cause fatigue?
I attributed it to the fact that he is still a smoker and still drinks, and I figured that would mess up with that medication at some point, and eventually that would lead to the upper abdominal pain, possibly in the kidney and liver.
Maybe.
And I don't know how it tied into the fatigue, but I just looked the medication up.
Yeah, and that's a good thing to do, because you whenever I give you a medication, it's usually for a reason. But you also want to make sure that the side effects of a medication aren't what's causing the patient's syndrome, because then you're just going to be spinning your wheels for no reason. So, lisinopril hydrochlorothiazide, what type of medication is that?
It's to treat high blood pressure and hypertension.
Okay, so what will it do to your blood pressure?
It'll open up the vessels to allow blood flow. Or lower blood. Yeah.
Yeah, more generally, it lowers blood pressure, right?
Yeah.
So if we take too much of it, what will happen?
It'll lower. You get dizzy. I'm sorry. I'm reading the comments.
No, it's okay. It's okay. Use your resources. That's good. So if you think about it logically, if your blood pressure medication decreases your blood pressure, if we take too much of it, it'll decrease your blood pressure too much, right? You're going to have a really significant decrease in your blood pressure. So one question that you're going to want to know with his medications is he taking it more than he's supposed to? Because that can cause the symptoms. You are right. So good. It's always good to take a look at the medications and see. It can cause low blood pressure. It can cause fatigue. It can cause dizziness. Lisinopril is a ACE inhibitor, and that can affect the kidneys. A lot of times, though, if they've been on it for a long period of time, it's not going to be the thing that's causing the kidney injury. But that's a good thought as well, and it's good to always look up those side effects. Okay, so Dr. Thomas, he had noticed blood in his urine recently, which he attributed to a UTI because he's had similar symptoms in the past, and so he drank cranberry juice because it was a brewing infection. So, is the blood in the urine significant? And if so, what do you want to do to check if it's even there?
I'm not exactly very sure, but I was thinking that's not usually normal, like the blood in the urine. So like other people were saying, like the UTI could be worsened, or like also they're like if something, like I remember in the notes, if there are certain like infections or like abrasions with certain organs, blood can spill into the abdominal cavity and affect that.
Yeah. So blood, you're right. Blood in the urine is not normal, and so we would definitely want to check if there is actually blood there. The things that can cause blood in the urine. So anything in the urinary tract, so from the kidneys all the way down to the bladder and out the urethra. So kidneys, ureters, bladder, urethra, there can be a lesion somewhere in that tract that can cause bleeding. And so UTIs can cause it because of irritation to the bladder. You can have a kidney stone lodged in one of the ureters, and the way that I think of it, just kind of scrapes that ureter all the way down, causing a lot of pain and causing some bleeding. And then anything else that can cause, that you can think of that can cause bleeding in the urine or blood in the urine?
I'm not really sure. Like maybe like other like if there were like perforated, well, not really perforated bowels, but like if there were like perforated ulcers, maybe that could cause bleeding.
Not so much in the urinary tract, but
Okay.
yeah, that would be more in the stomach and the GI tract, definitely.
Okay.
Yeah, but yeah, good job, Dr. Farida. What are you talking about?
You were asking what else could cause the blood in the urine, and I was thinking since we were talking about cancer and having like a higher risk patient for cancer, I was reading that kidney cancer could cause blood in the urine sometimes.
Yeah, so kidney cancer can definitely cause blood in the urine. Same with bladder cancer as well. So bladder cancer causes blood in the urine, and the main workup for hematuria, so gross blood, like blood that you can see in the urine, is a workup for bladder cancer. So definitely you want to think of cancer as if he actually has blood in the urine. So good. All right. Okay. So, and then in the last part, I'll go with Dr. Alfaro. We're saying that he has dark, sticky stools over the last week. What does that mean? What does that make you think of?
I would think that maybe he's having some kind of, maybe even constipation. Sometimes when you have constipation, you might have really weird bowel movement. Other than that, I'm not too sure.
Yeah, so constipation, definitely you're gonna have those like hard, round, pellet-like stools. If you're taking iron, that can cause a darker color to your stools. But what about like the sticky tar-like stools? Anything that you can think of that's indicative of?
I would say it's an effect of the smoking. I don't know how exactly it would affect it, but I think that would have to do with it.
Not so much the smoking, but okay. So Dr. Veronica, do you want to talk about what you're saying?
Yeah, so I think the like sticky blood stool can just be a bleed in the upper GI.
Why?
I guess because there's probably like blood mixing with acid somewhere there, like in
Okay.
the stuff.
So what happens when blood mixes with acid?
It looks like kind of like coffee grounds. So it's like, yeah.
Yeah, so it's gonna make it turn black. It's gonna make it turn like a darker color. If you vomit if you vomit that up, it's gonna be kind of coffee ground. It's gonna have a coffee ground texture, and it'll look like coffee grounds as you vomit it up, because the blood is basically being broken down by the acid in the stomach. And so as that happens, it's gonna oxidize, and it's gonna cause like this blacker color to happen. And so if you vomit that up, it looks like coffee grounds. If it goes the other way and it goes down into the bowels, it's going to mix with stool, and it's going to become like a tarry, sticky, black stool, and that's called melena, and it's indicative of an upper GI bleed like you're talking about. So good. So now we're starting to think that he might have blood in his urine. He might have blood in his stool. And so, Dr. Veronica, he denies fevers, chills, night sweats, vomiting, bright red blood in the stool, constipation, diarrhea, reflux symptoms, chest pain, shortness of breath. So with the fevers and chills, what if he's denying those? What is it less likely to be?
It probably means that he doesn't have an infection.
Yeah, most likely not an infection. And what about bright red blood in the stool? Why is that important to know?
I think because that shows that it's probably not a bleed in the lower GI, and since it's not as bright red.
So why is it bleed in the lower GI bright red?
Because it's not going through like the whole system, I guess, and it's immediate.
Yeah. So it's bleeding from that lower part of the GI tract, which is closer to the rectum and closer to where the stool comes out. And so less time to mix with the stool, less time to mix with acid higher up. So it looks more like fresh blood. And so if you have fresh blood, you're thinking lower or more distal in that whole tract. So things that are closer to the exit of where the stool is going to come out, right? So so bright red blood, you always think of lower GI, although with a very fast upper GI bleed, usually kind of in the duodenum or in the small intestine, you can have bright red blood still. It's just happening so fast that it's just it's coming out kind of how it came out of the vessels. So yeah, and if you have a brisk bleed like that, you're going to be a little bit more worried. Okay, so for the rest of the history, we already talked about the meds, the social history, the 30-pack year smoking history we talked about as well. The marijuana, the cocaine, I mean, he hasn't really used that in a long time, so probably not significant. And then the drinking of the beers, that's about average. I wouldn't be too concerned about it at this point, unless he has other signs of like liver injury, so like elevated liver function tests. So, all right. So, Dr. Safe, I'm going to give you the vitals. You interpret them for me. So, blood pressure is 110/66. Heart rate is 110. Respiratory rate is 16. Temp is 99. And O2 sat is 96 on Romare. What is your interpretation?
Okay, so I thought his heart rate was elevated for someone that's pretty dizzy because he's supposed to have a higher heart rate if he needs more blood pumping.
Okay. All right. So,
and yeah.
No, go for it.
Oh, okay. And I thought his blood pressure would be low because of hypertension.
Okay. So let's go with the heart rate first. So the heart rate is high, and you're saying because he's getting dizzy that it's high. Why? So what is the mechanism behind that? Why is it high? We kind of talked about it already.
I thought because he would need more. It's elevated because since he's dizzy, he would need more blood pumping. So it could be a circulatory problem.
Yeah. So the volume is in general, it might be low. So your heart's going to pump faster to help perfuse and maintain that cardiac output. So good. And then you said the blood pressure might be low. You said.
Yes.
Why?
Because when we need to find his normal blood pressure, because from before we said that his blood pressure would have changed.
Yeah, so he has a history of hypertension. He has a history of high blood pressure. He's on medications for it. So we don't know how well controlled he is. We don't know if, this 110 is where he usually sits with his medications, or if even with his medications, he's usually running 130 to 140, and this is low for him. So it's going to be important to know his baseline. I think this is actually a little low for him, if I remember right. So good. What about the temp?
The temperature, I didn't think it was too crazy. It looks pretty normal.
Yeah, it looks pretty normal. But what if I told you that for his pain, he was taking ibuprofen? How does that change things?
He said he had no fever, and I wouldn't think it would change anything.
Okay, so you're right. If he has no fever at home, his temp is 99 here, I don't think it's really infectious. But if he said, yeah, I was feeling warm at home, but I was taking some ibuprofen or Tylenol for my pain, then that 99 might be falsely low, because and you're going to want to know when the last time he took those medications. When was the last time he took those medications? So, yeah.
Oh, okay. Thank you.
Dr. Lee, Dr. Krista Lee. So what in the physical exam do you want to look at?
I would probably do an ultrasound. I would look at his abdomen, probably his lower and upper GI tract, focusing on the kidney.
Yeah, so before we get to the imaging and all that, you mentioned the abdomen. So yeah, we definitely want to take a look at the abdomen, right? So when we're doing the physical exam, it's going to basically be us examining the patient like, with our hands or stethoscopes and all that stuff. Yeah. So with the physical exam of the abdomen, we have tenderness and palpation in the epigastric region. Is that surprising to you that he has tenderness in the?
No, it's not. I would say because he's showing pain right up into his epigastric region, or near his abdomen, where maybe his intestines are.
Yeah, and so that's why he came in, right? He's saying that he has pain in his belly. He's pointing to that area when he came in. So the fact that he has tenderness when we push there, I mean,
no,
yeah, it makes sense, right?
Yeah, it's probably a little inflamed.
Yeah,
or it's tender. It's pressing back on you, maybe hard or distended.
Yeah. So we say there's no rebound or guarding. What does that mean?
I'm actually not sure.
Okay.
Rebound, I'm assuming when you press or you palpate someone's abdomen, it kind of like jumps back up at you. It's a little more flexible. It's less hard, maybe.
Close. So what rebound is like you're saying, we push down, and after we push down, so when we push down, we're focusing on a specific area. We're seeing, is that part tender as we push down?
Right.
Now the rebound is when we let go. Does that cause pain? Right. So if they have more pain when they let go, that causes kind of a motion wave throughout the abdomen that can cause that can show you if there's pain up anywhere else. And so the reason why that causes pain is because your abdomen has a lining of peritoneum. It has this additional lining that has nerve fibers that tells us if there is any type of inflammation in the area. So if you have a bleed in the abdomen, if you have if your bowel perforates and now you have stool in there, if you have an infection in the abdomen like acetic fluid or ascites that is infected, that can all cause peritoneal type pain. And so peritoneal pain or rebound tenderness just basically tells us there's something in the abdomen that's not supposed to be there, right? And so that's rebound. It's one of the things that we look at to see if this is surgical or not. The other one is guarding. So guarding is like the way that I think of it is you trying to protect your own abdomen. So you're pushing down and it feels firm. It feels kind of like hard, like a rock. And so when you feel that, what there's two different types. There's voluntary and involuntary. So voluntary is like you're in a lot of pain and you're thinking, oh, if he pushes down, it's gonna hurt. So I'm gonna guard. I'm gonna
clench.
Exactly. So you're gonna clench. You're basically abdomen's gonna flinch. And so you push down. It's hard. It hurts. That's a sign that there's some inflammation down there. But involuntary is even if you try to relax, the abdomen is firm, rock hard, rigid, and so you push down. It feels really hard. That means there's so much inflammation there that muscle is really contracted and you can't really feel anything. And so that is a very ominous sign. That means that there's probably something really bad going on, and you're gonna probably need some type of surgery, or you need to at least get evaluated by a surgeon. So very good job. Now the bowel sounds in all four quadrants just tells us that the bowels are moving. And then what about suprapubic tenderness? What does that mean?
I think that possibly means near the bladder. When I think of suprapubic, I think of the bladder, possibly near the uterus, or somewhere in the realm of like the ovaries. So suprapubic tenderness could possibly be maybe like an infection of the bladder or tenderness of the bladder. Maybe there's like a ulceration in the bladder, something like that.
Yeah, so suprapubic tenderness, if you look at the anatomy of that pelvic area, you have the skin, the muscles, and right underneath that is your bladder. And so if you have a UTI and that area is inflamed, as you push down, that bladder is inflamed, you're going to cause some pain, you have some tenderness there. So A lot of times suprapubic tenderness is going to be more the bladder, but you're right. There's a bunch of other stuff in that area, and you can have pain from that other or those other organs as well. So yeah, good, very good job. All right, so Dr. Parikh, anything else in the physical exam that you want to get?
I would. Do you want to maybe look at if he's like we mentioned ibuprofen to see if he's taking like too much, or if he's taking it like if he's taking it more frequently for the back pain maybe and that can cause like the mucus lining in the stomach to like dissipate so that the acid starts to burn the stomach lining.
Yeah, so I mean that's definitely a possibility, but he's not taking ibuprofen. So so what in the physical exam? So when you're examining the patient, what are you going to want to do, or what organ system or area do you want to take a look at to see if there's an issue?
Well, definitely the kidneys, because that's where the pain is in the lower back.
Yeah.
Sorry. So maybe like to see if there's pain to like palpations to like around that area to see if there's any inflammation or anything.
Yeah. So do you know what that's called?
I'm not sure.
So so Cva tenderness, right? So Cva is the costovertebral angle. So that's kind of this part of the back right here. I don't know if you guys can see. So so what I do is I put my hand on that area where the kidneys are, and I'm tapping really, really hard. And I put my hand there so I'm not actually hitting the patient, I'm hitting my own hand. But if the patient has significant inflammation of the kidney, they will jump up in pain. They'll try to swat your hand away because it's very painful. So something like a kidney stone or a kidney infection will cause them to jump up really high. If they have some other process going on, like let's say the muscles are tender, the ribs are tender, or something else in that area, they can have some tenderness, but they're not going to be jumping up like that. So yeah, so good job, Dr. Halam. What else do you want to take a look at in the physical exam?
I would look at, we looked at like the bowels and we saw that they were all fine. I would definitely make sure that he was able to like move all limbs, and that he looked like he was all there mentally, as far as like, is he like aware of what's going on? Is he aware of the pain? And then it was also noted like he's underweight. So you want to look at, okay, like how underweight is he, as far as like how much weight he lost?
Yeah, so good. So we want to make sure that he's neurologically intact, make sure that he's not having like a stroke or something. And then the fact that he's underweight is a very good pickup that if he looks malnourished, then we know that this is something that is actually more severe. It's affecting his nourishment as well. All right, and then anything else in the physical exam that you would want to take a look at?
I would say his neck was fine. Like there was no anything with the lymph nodes. I would say, could you press on like the belly, like on the front of the kidneys, to see if there was any issue like from the front side?
Yeah, I mean you can, and it typically wouldn't cause that same tenderness that you would if you kind of did that CVA tenderness in the back. Mm-hmm. But you can. What about, so we're saying that he has this dark tarry type stools, or he's reporting that. So what do you want to do in part of a physical exam?
Oh, that's a good question. I mean, I don't know, like pressing on the bowels, would that do anything? Could you like collect like a sample?
Yeah. So how are you going to collect a sample?
So you can collect a stool sample, and then you can do like a urine dipstick test.
You can, but how are you going to collect the stool sample?
Like just have the patient do it.
So we typically will collect it ourselves. So we'll use our finger. We'll do a rectal exam. We'll check whatever stool comes out. We'll wipe it on this card that we have, and put some solution on it. If it turns blue with that solution, there's blood in there. So if you do the rectal exam, it's bright red, you know that there's blood, but sometimes it can be mixed in with the stool. It can still look brown. And so that solution does help pick up blood when we can't see it ourselves. So yeah, so good job. All right, So Dr. Davila, what labs do you want to get? All right, Dr. Sophia, what labs do you want to get?
Definitely a complete blood count, and then probably bun and creatinine to check his kidneys.
Okay, so CBC has a white count of 6,000, hemoglobin 7.2, platelet of 150. What's significant there?
I think the hemoglobin's pretty low, which kind of makes sense with like his dizziness and fatigue.
Yeah, so he's pretty anemic, right? So with that hemoglobin, what are you gonna want to do for him?
Make sure he's getting enough oxygen.
Yeah, so his oxygen saturation is good. What else can you do to help him out?
I'm not sure.
So Dr. Yip, what do you want to do to help him out? Or Dr. Sophia, what if you look at Dr. Yip helping you out, what do you want to do to help the patient out?
Blood transfusion.
Okay, good. How much blood do you want to give him?
Not sure what the normal amount is.
It's okay. So we typically would want for brisk bleeds or bleeds in general, we want to bring them up to about 8 hemoglobin of 8 at least. So 1 unit would technically should bring him up to about like 8.2, 8.3. So it's one unit will give you a bump of 1. And so 1 to 2 units is fine. He ended up getting 3. So, but that was because he still had some bleeding issues afterwards. So, Dr. Yip, we didn't hear you talk. Sorry. All right. So, what about the? Okay. So, Dr. Yip, is your mic working? Because I can call it right now. Maybe not. Okay. So,
Can you hear me now?
Now I can hear you. Yeah.
Oh, okay.
Okay. So, we got the CBC, and then they had mentioned that we wanted to get a BMP and look at the BUN and creatinine. So, creatinine is 1.8 with a baseline of 0.7. The BUN is 40. The rest of the lights are normal. So, what's significant about those labs?
So for the creatinine was pretty high, so I was thinking it was like a loss of the kidney function, or like maybe your kidney wasn't functioning as well.
Yeah, so he has some type of kidney injury, right? What about the BUN?
I'm not really too sure about that part. Sorry.
Yeah. So the BUN is also filtered by the kidney. It can be a sign of kidney injury. So it's blood, urea, and nitrogen. So the BUN is a breakdown product of cells, and specifically for the blood, as it breaks down, it releases BUN. And so that BUN is going to be reabsorbed. If it's in the GI tract, it can be reabsorbed back into the blood and cause an elevation. And so elevated BUN as compared to the creatinine, so like elevation of 20 to 1, or 20 times higher BUN than creatinine can be indicative of a GI bleed. And so for this patient, if you look at the ratio, it's higher than 20 to 1, so you might be having a GI bleed there. So good. Any other labs that you want to get?
I'm not too sure, but just like based on the labs, I saw the T-bili was a bit elevated.
Okay, so that what can that indicate?
I'm sorry, I was looking through my notes.
It's okay.
Yeah.
So the T-bili in this case is a little elevated, but it's not super significant unless it keeps going up. T-bili can be transiently elevated. Usually, it's going to be a liver problem. It's going to be liver's inability to process the bilirubin. But bilirubin is a breakdown product of blood as well. So as blood cells die, you're going to have an increase in bilirubin. So he might be having a slightly increased bilirubin because of that. So I wouldn't worry too much about it unless it's going a lot higher. So yeah, so good job. All right, so Dr. Brittany, any other labs you want to get?
Maybe a lipase check.
Okay, so lipase was 25. What does that mean?
I actually wasn't sure of what the normal level of lipase was because I don't know what the units are for it.
Yeah, so I realized after I sent it, somebody asked like, "Hey, what are the units?" I realized that there's more than one way of doing the lipase unit. So that's normal. The 25 is normal. But if it was elevated, what would you be thinking of?
If it was elevated, I would think maybe a pancreas problem.
Yeah. So elevated lipase tells us usually that there's some pancreatic problem going on. Any other labs that you want to get?
Not that I know of. Because I mean, based on what was given, aside from everything we've already talked about, they seem kind of normal. Like his AST and ALT was normal.
Yeah. Did we talk about the urine yet? I don't know.
Oh, no, we didn't.
Okay. So what about the urine? The specific gravity is 1.03, and there's blood in it, otherwise normal. So what does that tell us?
I don't actually know what the specific gravity of 1.03 means.
Good. So that means that we can learn a little bit. So the specific gravity is basically telling us how concentrated the urine is, how much dissolved solutes are in the urine. So if you think about like when you're dehydrated and you're going pee, your pee is usually darker. It's darker yellow. Sometimes it has more of a smell to it that is that's stronger because more things are dissolved in the urine. So high specific gravity just means that it's more concentrated. So if you have concentrated urine, it means what?
Something's wrong with the kidney functions, or like you're not drinking enough water, I guess, to dilute the milk in it.
Yeah, you're probably just dehydrated. What about the blood? We talked about this earlier. Is blood in the urine normal?
Definitely not normal.
Yeah,
would be maybe like a kidney stone or something, like something blocking the tract.
Yeah, exactly. And so why? So one possibility that the patient was thinking of was if this was a UTI. So why is this not a UTI? Based on urine.
There wasn't really any pain in his lower pelvic region.
Yeah, but what about for this urine test itself? Like, why isn't it not a UTI?
I'm kind of blanking at the moment. Or I mean, someone said there isn't his white blood cells are not elevated, and that's like a sign of not an infection.
Yeah, so with UTIs, a lot of times you're not going to have an elevated white blood cell count because it's pretty local to the bladder. But when we look at the urine, this is just a dipstick. So this is not the most precise test. You're basically taking the urine and dipping this paper in it and looking at the color changes to grade what is going on with the urine. And so other factors that we look into with the urine dipstick are leukocyte esterase and nitrites. And so both of those are indicators for an infection. The leukes are basically a surrogate of white blood cells in the urine and in the bladder. And nitrates are, I believe, if I'm remembering right, it's like a breakdown product that indicates that there might be a gram-negative bacteria in the urine. But I have to double check that because for some reason I'm thinking that might not. I think that's right, but I have to double check it. So, but both of those are indicators of a possible infection. And so if the urine is otherwise normal, there's blood but no other signs of an infection, maybe not an infection. We want to confirm. We can get a UA to be more precise and also look at a culture perhaps. But this urine is not screaming infection to me. So there's something else going on there. But yeah, good job. All right. So Dr. Yamini, can you summarize the case and tell me what do you think is going on with this patient? What is your diagnosis for this patient so far? All right, let's go with Dr. Alyssa.
Hi, I'm sorry. I actually zoned out the past 20 minutes because my food just came, so I don't know what happened at the end.
It's okay. I'm sorry, I forgot. I was supposed to not call you. So sorry. I hope you enjoy your food. It's okay.
No, I'm sorry. I was totally summarized. I know the beginning, but I don't know what just happened at the end.
No, it's okay. It's okay. Go enjoy your food. Don't worry about it. If you have questions though, after, you just message me. We can talk about it also.
Okay, I'm
right.
sorry.
It's okay. So
Okay,
Dr.
thank you.
Garcia, can you summarize kind of and tell me what's going on with this patient?
Can you hear me?
Yeah, I can hear you.
Okay. So I had first initially thought it was some type of infection for the kidney, but I think everything kind of rules out infection.
Okay.
So I would probably say some underlying kidney problem, possibly CDK.
Okay.
Or since he does have a high risk of cancer, possibly that as well.
Okay. So we have blood in the urine, and we have blood in the GI tract, right? He's pooping blood as well. What do you think is most likely? I would hit both of those.
I'm sorry, I couldn't hear you.
So he has blood in the urine and blood in the GI tract in the stool. What do you think could possibly be affecting both?
I would probably say cancer that metastasized. Is that how you say it? Sorry.
Yeah. So cancer that metastasized. That's a possibility. Is it possible that there's two things going on with this patient at the same time?
I would say it's likely just because of how everything's smushed together in the abdomen, but yeah, I'm not too sure.
Yeah. So it is possible that you can have two completely unrelated, events going at the same time. You can have a urinary problem that happened at the same time as having a GI problem where you're having bleeding from both. So that is possible. Now, is it likely, Dr. Garcia?
I would say no.
Right? Because it would be strange for both those things to happen around the same time. It's definitely possible, but my style of medicine, and this is only personal to me, is that if there's two things that are happening simultaneously, it's too much of a coincidence for it to be happening at the same time. So I like to try to find things that tie everything together. That doesn't happen all the time, so you never want to kind of pigeonhole yourself into just that. But for me, and the way that I think of it, if they're happening and they're both occurring around the same time, they're both new, it's too much of a coincidence to say that they're unrelated. So good job. So Dr. Patel, do you agree with Dr. Garcia that this might be something like a cancer?
Can you hear me?
Yeah, I can hear you.
Okay, so I think it could be cancer just because he's showing symptoms of some obstruction, and if you take into account his 30-year smoking history and his hypertension, his vessels could have been constricted somehow as the time progressed. So something, and plus he's not eating as well, so the nutrients, if it's cancer, it's pulling all the nutrients from whatever he's taking in, and that's causing his fatigue and everything else he's experiencing.
Good. And so somebody's in YouTube is asking if this could be ulcerative colitis. What do you think?
Forgot what that is.
It's okay.
1 second.
So,
I don't think so.
So ulcerative colitis is an autoimmune process that attacks your bowels, and it can cause blood in the stool. It usually will cause more bright red blood. It wouldn't really cause melena, so that dark tarry stool, because ulcerative colitis is going to be a lower GI bleed, versus what we have right here is probably an upper GI bleed. And so the other thing with ulcerative colitis, it doesn't usually cause blood in the urine. So that's why it's less likely to be ulcerative colitis. It's a possibility, but it's going to be lower on our differential. So good. So good job, Dr. Patel. All right, so Dr. Chef, what do you want to get for this patient? If we're thinking this might be a cancer, what do you want to get?
I'm not actually sure what we should get for him.
Okay, so do we know where the cancer is?
Well, we know it's related to his kidney because of all the labs and everything.
Yeah, so potentially the kidneys. We also know that there's something going on in the GI tract as well. So how are we going to pinpoint where it's at?
I'm not sure. I think we just get like CTs and do a urine test sample like we did before, but I'm not sure.
Yeah, so we're gonna want to get a CT scan, right? So do you want to get that CT with contrast or without contrast?
Sorry, it keeps cutting out. Without contrast? Oh no, with contrast.
Why do you want to get it with contrast?
So we could see like you might highlight certain areas that are blocked or something.
Yeah, so the contrast is going to help light up cancer because contrast goes in the vessels and cancer tries to recruit more vessels, so it's going to light up more than the surrounding areas because it's more vascular. And so we would want to get it with contrast, and we want to get the other reason we would get a contrast is like if we have an abscess or some other infection, or if we want to take a look at those vessels themselves and get an angiogram. So good. But Dr. Ponce, why are you saying without contrast?
I would say without contrast because if there's an injury in the kidneys, maybe it could be worsened if it was with contrast.
Yeah, so if the patient has a kidney injury and we give contrast, contrast can be toxic to the kidney, and so it can cause a pretty significant kidney injury, cause some renal failure as well. And so we don't want to give it, we typically don't give contrast to patients with acute kidney injury. And so for this patient, we got it without contrast. And so the CT chest, abdomen, pelvis was limited due to the lack of contrast, but there was a 3 centimeter mass in the antral portion of the stomach. So that's kind of that more distal part of the stomach, closer to the duodenum. And then a 5.5 centimeter irregular solid structure in the superior pole of the kidney. If Dr. Ponce, which kidney do you think is affected?
I'm not sure.
So left or right? It's okay, just guess one.
Left.
Why the left?
Because maybe.
Other than the pain there, because Dr. Azam is right, he did have pain there, but why is left more likely?
Because he had tenderness.
Yeah. So
there's tenderness noted on the left.
Okay, but is there any other reason why it's more likely to be the left side?
I'm not sure.
It's okay. Dr. Sophia, why?
I think if there's a mass on his stomach, that's like more on the left side, so it would probably also be the left kidney just because it's like in a similar region.
They're closer together, yeah. So if it was on the right kidney, it would have to transverse the entire abdomen to get to the stomach, so that's less likely. It would probably go to another organ before it hits the stomach. And so the left side is really close in proximity, so it's more likely that it was from that left kidney. All right, so Dr. Melissa, what do you think is, so we have these two masses, so a 3 centimeter mass in the stomach, a 5.5 centimeter in the kidney. Which one do you think is the primary cancer?
Like which one should we be performing the scan on first, the biopsy?
So yeah, we're gonna want to get a biopsy, but which mass is the original mass?
Would it be the stomach?
Why?
I would say it's due to the GI tract issues that were happening in the upper region. So all the bleeding that was happening there with the stool could potentially be issue.
Potentially, but the one that's bigger is usually the primary because it has more time to grow. So the kidney is more likely the primary. But having said that, which one do you want to biopsy?
Well, typically then if it's the bigger one, we would do the biopsy on the kidney, but I would say still stomach because that's where the bleeding is occurring, like the upper GI and everything.
Yeah, so and it's easier to get to, right? So we can easily do an EGD, so put a scope down, take a look at the stomach and see what's going on there. And then you're right, if it's bleeding, we can clot it off. So we did an EGD, which showed a ulcerated mass in the antrum of the stomach with notable oozing. A biopsy was taken and the bleeding was clotted off. And so, so good. Let me see here. Dr. Alvarado, is there anything that you want to do for this patient? Do you want to admit him to the hospital? Do you want to send him home? What do you want to do? All right, so everybody's saying keep him in the hospital. So yeah, we're gonna want to keep him in the hospital. We're gonna want to make sure he's stable. Give him some fluids, give him some blood, like we talked about earlier. And I wouldn't wait for the results of the biopsy just because sometimes that can take a while. So if he's stable, everything else looks good, we can probably send him home while we wait. And so the biopsy returned with a renal cell carcinoma. And so the biopsy was obtained from the stomach, so it was likely metastatic renal cell carcinoma to the stomach. So he was referred to hem-onc, started on monoclonal antibody therapy. He had multiple hospitalizations for the GI bleed because he kept bleeding. They kept having to do EGDs and trying to stop the bleed. And he required multiple blood transfusions. So, so the reason why I chose this case is because, you know, there's a lot going on in the abdomen. There's a lot that can potentially cause you to have abdominal pain. And because everything's so close together, you can have kind of similar symptoms for different organs, and they all sound the same. And so the way that I want you guys to think about it is think about what's in the area. And so if a patient comes in with abdominal pain in one area, think about all the organs in that area that can potentially be causing that pain. Then I want you to think about what in the history are you going to ask that patient to get them to get to that right diagnosis. Then back it up with your physical exam and your vitals. What are you going to focus on that physical exam to try to pinpoint exactly what organ or what system is affected? And then from there, try to confirm all that with your labs and your imaging. And so you have to kind of have this process that you go through to really pinpoint abdominal pain because there's just so much going on for that area. So I hope this was helpful in helping you kind of know how to think about it so that when you have less information, you are able to do it in a more systematic process. Dr. Parikh is asking, do we submit our notes for this case? Hold off on submitting them unless you wrote notes for the session. Send those to me if you did. But if you wrote them for yourself, for your own, knowledge or for your prep, wait till the end, and you can submit all your abdominal pain notes for the end, at the end. All right, so I'm behind for the next class. So if you guys have any questions, send me a message on through the classroom or message me on Instagram or something like that. I hope this was helpful, and we're going to be talking more next week. All right, thanks guys. Bye.